and inimitable President Dr. Garg. This is a curated series. This is an open access series for everybody, medical and paramedical people interested in biological psychiatry. It's a niche topic, and we have only the experts in the field sharing their thoughts and insights and their knowledge with us. It's also a popular series, and that's why we've made it to year 2. And it's a happy birthday to us, and hopefully we can all blow a candle and maybe cut a cake at our own residences to celebrate today's event. With this, I would like to invite our Vice President, Dr. Sunil Mittal. He's a senior psychiatrist from Delhi, and a lot of us have learned a lot from him. And he's also the incoming president of Indian Association of Biological Psychiatry, and he's going to share some welcoming remarks. So.
Thank you, Rukshada. Firstly, happy birthday to the IABP CME. It's the second anniversary. And as would have it, the second anniversary has got a special speaker, someone whom everybody wants to listen to and hang on to every word that he says. So the CME initiative, which was taken by the IABP, is for not just the PG students, but for each and every member or anybody who's interested, since it's being live streamed, and to update their knowledge and also become better professionals in doing so. And in today's CME, we have 2 chairpersons. It's my honor to introduce the 2 chairpersons. One of them is unable to join at the moment because of connectivity issues, but we hope that he would be able to join soon or midway during this CME. The chairperson, Dr. UC Garg. He is the president of the Indian Association of Biological Psychiatry. And like we were talking a little bit back, Rukshada and I were discussing, he's, like she said, he's an astute and very, meticulous president that we have had, who has steered and guided IABP in different, developments. You look at the journal, you look at the CME series, and so many other things that have been happening during this period. He is a senior consultant psychiatrist based in Agra. But the base is Agra, and just like the Taj from Agra, he is known all over the world. So that's Dr. UC Garg in a nutshell, because you can't actually fit him into even a large volume, if one has to say so. So Dr. UC Garg will be chairing, and the second chairperson, Dr. Venugopal Jhawar, who's hopefully should be able to join, the connection being poor, like I said. He is, again, one of the founders of the IABP, and currently the president of the Indian Association of Private Psychiatry. And at the same time, he is one of the leading figures who's, again, well-reputed, known all over the world for his knowledge, for his depth and breadth of knowledge in every branch, whether it's geriatric psychiatry or it's biological psychiatry or it's to do with clinical work or clinical research. So he's our second chairperson for the evening. And these 2 chairpersons, I'm sure, fit the bill for today, because the speaker is a very tall figure in psychiatry. And for that, I hand it back to Rukshada to take this forward.
Thank you so much, sir. I think I would ordinarily have requested chair to introduce the speaker, but I cannot let this go without saying a few words about him myself. He's a founding member of IABP, but he's also a founding member of my biological psychiatry knowledge. As such, I had the pleasure and the honor, and indeed such a blessing to be a student of Dr. Vahia. And I think my interest in biological psychiatry, if not piqued by him, would have been very, very latent and growing. He's taught a lot of the contemporaries that I admire lot and I learn from even now. So he was really the perfect choice for us. Albeit the biting sarcasm and the humor, but it's always witty. And because he has his own sweet charm and in a different and his manner, what he says does stay a long time with you, isn't it? He's the professor emeritus at Cooper Hospital. He's also going to be show off and brag here that we're from alumni from the same institute. So any occasion for me to rub shoulders with him or attach my name anywhere near him is always a pleasure. With this, I'm going to again, Dr. Sunil Mittal has very eruditely already introduced our chair for the session today. But again, I'm going to take privilege of my position and say a few more words to Dr. Garg. Like I was just mentioning casually before we started the session, a lot of hand-holding by Dr. Garg for me, and he's always such a support and very clear in his thoughts and always such a calm presence, but very passionate. Without him, I don't think we would have embarked on any of these journeys that IABP has taken over the last 2.5 years. His leadership and his insight and his far thought has made it possible for us to inaugurate our journal. That's going to happen later in this month by our editor, Dr. Aleem Siddiqui, who's also joined us today. Of course, the First Friday CME series wouldn't have happened without him. And we also have to thank Dr. Sunil Mittal for the newsletter that we have every month that we have. And a lot of the highlights of the talks that we do on the webinar, we also publish and post on the newsletter. So we really, really take advantage of the speakers and their mercy on us because we don't really let them off the hook even after the webinar is over. So with a few more words about all of this, I'm going to hand over the session to Dr. Garg to take it forward. Dr. U.C. Garg, Senior Psychiatrist from Agra, my president from IABP. So.
Thank you, Dr. Ruksida. Good evening, all. It is my privilege in the office, on behalf of Office of President, Indian Association of Biological Sciences. I welcome all audience, our esteemed speaker, Professor Vihang, our Vice President, and other office bearers. Before I go ahead, I would like to congratulate Dr. Ruksida Saida for making this First Friday CME executed in a very decent way and very regular way. And I must congratulate Dr. Sunil Mittal also for floating the idea of holding this First Friday CME about 2.5 years back. So both of you deserve the mention, and I clap for your ideas and execution. Thank you very much. Dr. Vahia, around 18 years back, I was the chairperson in a session where you were talking about the recent advances in treatment of depression. 2005, Chandigarh NSIPS. At that time, I was the convener of Biological Psychiatry Specialty Section of IPS, and you were the speaker there. It is my great honor for me that today I am again witnessing the same speaker having a international repute, and the topic is very much pertinent, the newer trends in psychiatry. We are seeing day by day that how the newer techniques of investigations, how the digitalization and the genetics and vast scope of newer treatment modalities have made so much psychiatry different from the previous psychiatry. I'm definitely sure that this lecture will be going to help all the clinicians and academicians also for their future programs. So with these words, I request Dr. Vahia sir to kindly give his deliberation on the topic today. Thank you, sir.
Thank you, sir. Thank you, the office bearers of IABP. And thank you, Dr. Ruksida, for asking me to be making this presentation on this auspicious occasion of the second anniversary of IABP. I guess my slides are visible. Are my slides visible?
Yes.
Yeah. So I've been asked to speak on changing trends in psychiatry. And that's a very, very relevant topic in the days today. But as we talk of changing trends, the most important point that I would like to make is that we have now more or less zeroed down on the fact that brain is the organ of psychiatry. And there is sensational research trying to bridge the gap between brain and mind. And that's largely the point of my presentation today, with brief reference to some other aspects. I have no conflict of interest in making this presentation, but there is a clarification. I'm a standalone psychiatrist now. And in my books, there is a parallel between a car driver and a clinician. How? A good driver of a vehicle needs to know salient features of the vehicle and ensure a smooth ride for the passenger. A good driver does not need to micromanage his vehicle. He doesn't have to know the size of the piston or the crankshaft, and he doesn't need to know at what speed the automatic gears change, and he doesn't need to know the difference between driving a Tata versus a Tesla. It's not his job. His job is to drive the vehicle safely and deliver the patient to the destination safely. Likewise, a clinician's job is to be aware of major research occurring in the field of mental health and mental health management, not necessarily be aware of every little minor research detail to be a good clinician. With this context, I also want to remind everyone what Winston Churchill said, that success consists of going from failure to failure without loss of enthusiasm. I've had plenty of failures. Enthusiasm, I'm trying. So, when talking of failures, before the 15th century, people with mental illness were jolly well kept as a part of the society. It's by the 15th century, there was a perceived need to protect the society from the mentally ill. And that started the era of madhouses or asylums. Almost 100 years later, there was a realization that epilepsy and abnormal behavior are treatable. Madhouses became therapeutic asylums with some hope of providing adequate care. The neurologists attached to these therapeutic asylums dissected the brains of the mentally ill and clearly said that large number of mental illnesses are actually degenerative disorders of the brain. This would have progressed further, but it was Sigmund Freud and Emil Kraepelin who had nothing of it. They put an abrupt end to the first wave of biological psychiatry, but they did three important things. The first is they de-demonized mental health. Mental health was not for the demons to cause an illness. They also said that mental health or mental illness had some kind of a familial propensity and trends. They were not sure of the intriguing relationship between gene and environment. We are not very sure of it even today. But what the Kraepelinian and Freudian era did was it brought mental health out of the asylums and the research into the universities. Then came, by the late 20th century, brain imaging, the second wave. We could actually see the brain of a live person when at rest and when activated with specific tasks. We realized that a whole lot of mental functions like thoughts, feelings, sociability, and mood had something to do with dysfunctions of the brain, functional dysfunctions of the brain. And the etiology of mental illness shifted from just the psychosocial factors into studying the genetic and the environmental factors that triggered a mental illness. Let's not forget that in the midst of all this, the need to make the person clarify thought process, psychotherapy to make the patient unwind the cluster of thoughts, rewind the cluster of thoughts in a more standardized fashion, and achieve clarity through psychotherapy and communication is just as important as understanding the brain functions in mental illness. Then we are now finally into the third wave of biological psychiatry. Thank the Lord for that. So what is this third wave? When we say third wave, we essentially talk of molecular psychiatry and translational psychiatry, but their meaning is not particularly clear in the minds of many. So molecular psychiatry emerged from biological psychiatry. Giulio Licinio, who founded the Journal of Molecular Psychiatry, prioritized integration of molecular medicine into clinical psychiatry. His emphasis was that mental disorders are brain disorders and that mental disorders are not physical disorders. So Giulio Licinio pioneered this concept of mind being an epiphenomena of spiritual, biochemical, cellular, and molecular processes of the brain. Now, so what's molecular psychiatry? Molecular psychiatry studies the biological processes associated with mental illness and recommends a treatment, whereas translational psychiatry promotes personalized medicine. What do we mean by that? Translational psychiatry bridges the treatment gap by giving us a good understanding of what kind of brain dysfunction is responsible for a particular symptom complex. And the formula of translational psychiatry is to formulate accurate and individualized treatment based on clinical, genetic, and environmental factors with information and not just the eminence-based opinions. So we distinctly moved into evidence-based psychiatry with the third wave of biological psychiatry. And what are the kinds of translational research? Like the Delhi airport, there's T1, T2, and T3. Develop the treatment, test their efficacy, and disseminate the implementation of those researches. Let's not forget that psychiatry has basically come out of neurology. The fundamental of psychiatry was always in neurology till about 1886 to 1895, when Sigmund Freud, the father of modern psychiatry as it's commonly known, introduced psychoanalysis. After Sigmund Freud passed away in 1939, his theory of psychoanalysis had firm holding on the practice of psychiatry. This went on till about 1960 worldwide and 1963 in India. In 1963, Dr. N.S. Vahia was the last ever psychiatrist to have been the president of the Neurological Society of India. What happened? By the year 2000, there was a realization that there is some association between mind and the brain. And psychiatry and neurology came together under the rubric of behavioral sciences. Wow. This was in Europe, which completely missed out on something that had happened in the year in USA 40 years before Sigmund Freud. We all know this case, the famous case of Phineas Gage. Dr. John Martin Harlow actually was the first psychiatrist to have observed some association between behavioral changes and brain injury, traumatic brain injury. On the fateful night of September 13th and 14th of 1848, Dr. John Martin Harlow was called to examine Mr. Phineas Gage. He was to hit this tamping iron to a rock after his assistant lit the gunpowder. He missed the timing and the tamping iron went through his eye and came out of the head. For those of us who are interested, the skull and the notes of Sir Martin Harlow, as well as translated in contemporary language, are on display in the New England Journal of Medicine Museum on the 5th floor. What Martin Harlow wrote is very nice. In 1860, when Phineas Gage died, his body as well as the tamping iron were sent to Harlow, who has put it in the museum. Dr. Harlow writes that immediately after the injury, he was able to walk, talk, remain lucid, and answer all questions about his injury. But his recovery was not complete. He had distinct changes in personality. He was difficult to deal with. He remained unemployed and died of epilepsy in 1860. Reread this in modern psychiatry language. Immediately after the onset of mental illness, our patients speak rationally and answer questions about the illness. But in as many as 60% of the patients, by our own submission, the recovery is not successful. At the best of our results are 30% recovery rates. So, we also know that so many of our patients become difficult to deal with. The families want them to be set aside in somewhere. They become rather aggressive and they are difficult to be employed. And the incidence of epilepsy is higher in our patients of mental illness. So, it took some of the opinion leaders, noteworthy being Professor Lou Judd, who conceptualized the project of Decade of the Brain. He could persuade senior President George Bush to sign the presidential proclamation of the Decade of the Brain between 1990 and the year 2000. I happened to have met him personally one-to-one over a dinner, where he said his only regret was that it should have been a century of the brain. Notwithstanding that, in this Decade of the Brain, there were 4 major national studies or plans on associating brain functions with mental illness. So, by the year 2000, neurology and psychiatry came back together under the rubric of neurosciences, where basic psychiatry and basic neurology, or the core psychiatry and core neurology, retained their identity, but there was an emergence of a whole new segment of neuropsychiatry, and a large amount of research then was on depression. The clinical impact of the Decade of the Brain was shift in orientation from psychoanalysis, psychodynamic, and psychosocial etiology to brain-based understanding of mental illness. Physicians sharpened their clinical skills, and there was a shift in the pattern of clinical assessment. We entered now the era of designer drugs. But remember Husseini Manji, the father of ketamine therapy for depression. He says, we as clinicians need to remember that our patient management is beyond the protein molecules. We are actually treating persons with careers, life, and family. And we should be able to look at the patient in totality and not just a segment of conceptualized brain disorder. The impact of this decade of the brain and the impact of Hussein Manji's conclusion is how we assess depressions. When I was a resident, it was common to think of depression as a disorder of emotions, and sometimes it also looked at the behavioral aspect or reflections of emotions. And then came this understanding of the physical symptoms associated with depression, which then formed the fundamentals of liaison psychiatry. A psychiatrist today goes beyond liaison psychiatry and thinks of cognitive bias and cognitive deficits in patients of depression. A talk on cognitive bias and cognitive deficits of depression is a topic for one of the Friday musings by itself. But go back to Lou Judd and the decade of the brain. Think of this 1987, the year when Professor Lou Judd joined NIMH, and 3 years before, this thought of decade of the brain came to his mind. That was the birth of molecular psychiatry. It occurred in 1987, where Ron Duman and Nestler founded the Laboratory of Molecular Psychiatry under the joint efforts of the state of Connecticut and Yale University. Thus was the origin of molecular psychiatry, which was very, very uncomfortable for psychotherapists and psychoanalysts. So there was sarcasm. It was called the Laboratory of Molecular Fear or Laboratory of Molecular Psychoanalysis. But remember, 1980, the hypothesis of the molecular psychiatrists was that abnormal behavior originates in the brain. Mental illness is no different from disease of all other organs, and psychiatric disorders have fundamental molecular lesions. Now, what do we mean by molecular lesions? The fundamental lesions in patients of mental illness has something to do with the DNA, RNA, and the proteins. And Dr. Duman and Nestler proposed that if we can identify the lesions, we can understand how they occur, we could translate it into strategies to either reverse or at least prevent the disorder from occurring or spreading. So, biological sciences, how are the trends? Just take a look at it. By the 17th century, we knew that insanity had something to do with the brain. Not knowing exactly what, but something to do with the brain, probably a degenerative etiology. We understood the nerves and the nerve endings and the synapses. By 1952, we had this drug therapy based on synaptic receptors, and we had a whole lot of medicines coming up between 1950 and 1980. We were thrilled till we realized that there were too many lacunae. All was not well with psychiatric drugs. Very often we got the patient out of one syndrome and pushed them into an iatrogenic syndrome. So by mid-90s, there was search for the answers. And this desperate search for the answers gave birth, or at least contributed to the birth of molecular psychiatry. Nestler and Duman were joined by the two Georges, George Henningal and George Agajanian, who helped come up with publications of molecular psychiatry. The first book came out in 1993. The first journal of molecular psychiatry came out in 1996. And the first journal of translational psychiatry came in 2011. Why the delay? So, we by now realize that genetic mutations are linked to the psychiatric disorders, and these mutations occur early in embryogenesis. The researchers were very clear that person who eventually develops a mental illness is actually born with the propensity to get into this illness given sufficient trigger. So the embryogenesis mutations, they impact early brain development, cell division, differentiation of survival of cells, exon path finding, dendritic architecture, and in brief, in one word, the embryonic, the mutations during embryogenesis changes the wiring of the brain circuits. This was an impetus to explore molecular mechanisms of complex brain illnesses like anxiety, depression, schizophrenia, aggression, and other syndromes. When we say molecular mechanisms, it's very clear. It's not physics, it's biochemistry. When we say molecular mechanisms, we mean DNA, RNA, and the protein synthesis and degradation. Just the proteins, the DNA and the RNA. And the molecular and translational psychiatry focus on identifying the DNA, RNA, and protein synthesis mechanism that induce mental changes. And the aim is that once if we can identify more specific ways of studying or preventing these mutations, we will have proper treatment, or we might even reverse or prevent the neuropathology of mental illness. Earlier experiments were all on rodents or animals, and the research was slow because there were animal activists, and rodents you require several thousands before you can do something, which is not easy and very expensive. Till in the year 2015, Stewart got this zebrafish animal model, zebrafish model, not animal model, zebrafish model for translational research of CNS disorders. Zebrafish has well-characterized neural development, which is highly genetic homologous to mammals. What's more, zebrafish has a neurotransmitter systems where one could study the neurotransmitters, neuroreceptors, transporters, and the systems of synthesis and metabolism of neurotransmitters. And the way this becomes easy is because, one, zebrafish is easy to breed, but more important, zebrafish in its embryonic and larval stage is transparent. So one could actually see what's happening inside and analyze the mechanisms of development of the brain through what is known as high throughput screening. This high throughput screening, or HTS, is used by the cancer researchers for gene therapy. It's a automated, sophisticated equipment which can rapidly test thousands of or to millions samples of biological activities simultaneously. Not only at the level of the organism, at the cellular mechanism, at the pathways, but also at the molecular mechanism. It's not just the cells, but also the DNA, RNA, and the proteins in the cells, all during embryogenesis in a zebrafish, because it's transparent and easy to study. What's more, it's now known that these zebrafish also have key mediators of psychiatric symptoms and diseases, which are glutamate, GABA, acetylcholine, and monoamines, and histamine. These are today the probes for research into molecular psychiatry. So, there are opponents of these biological theories. They advocate non-biological theories. Most of them oppose the views against core concept of psychotherapy. Anybody who's against the core concept of psychotherapy is a complete no-no in their books. They are not able to explain how psychotherapy works, in spite of the fact that there is enough data to say that psychotherapy itself modulates neurobiological processes. That with psychotherapy, a person can actually rewire the brain to take distress out of the system. So applying basic research of molecular psychiatry to clinical strategy, it's not easy for several reasons. And the handle of the probe is psychopharmacology, where pharmaceutical industry comes in. What's more, converting molecular theories into clinical practice is not spontaneous. It requires a long process of thoughts. So Lisiano founded a sister journal called the Journal of Translational Psychiatry. So on the 21st century, we can say that molecular psychiatry provides understanding of the biological basis and the advances in rationale and disorder of specific pharmacology, whereas translational psychiatry is like bridges science with practice and policy of mental health care. An example of molecular psych processes translated to help the patient is the biomarkers. So what do biomarkers do? They are the potential tools for improving prevention, diagnosis, drug treatment, and development for development of psychiatric processes. Traditionally, mental illness is classified by symptoms. Hence, there is a lot of heterogeneity, 2 out of 5 or 5 out of 9. You can't have a homogeneous group of patients for any research or clinical work. So there are flaws in eliciting uniform response to treatment. What the biomarkers do is that they will stratify groups within the syndrome. Within the DSM, you can have biomarkers which identify a homogeneous segment of patients. And biomarkers will thus improve the treatment options by formulating focused treatment options. There are 6 kinds of biomarkers. There are pharmacological biomarkers, productive biomarkers, safety biomarkers, risk biomarkers, diagnostic biomarkers, and biomarkers of monitoring the patient's cure. All these are interlinked. So if we study one, we automatically get a hang of the other biomarkers. There are 5 domains of biomarkers: genetic, transcriptomics, proteomics, metabolomics, and epigenetics. So many of our colleagues talk about epigenetics. The others are difficult to figure out at this point in time. And despite this limitation, there is a whole team of researchers who are actively working at developing valid, clinically reliable biomarkers of psychiatric disorders and indicators of treatment to predict the treatment response. This will minimize trial and error switches of medication and eventually set a path for greater personalized medicine in mental health care. Again, to illustrate an example, molecular psychiatry of schizophrenia. There is much understanding on the brains of patients who have developed schizophrenia. But we have very little understanding in understanding the brains of lifetime risk of schizophrenia based on DNA sequences. At this point in time, there is 20% reliability of finding out patients, that's out of 100 patients that you say are likely to develop schizophrenia, probably 20 of them would develop. There are large-scale exome sequences studies that have identified single mutation risk for schizophrenia. Sanjeev Jain has done a lot of this work at NIMHANS. There are 6 genes. So even now it's polygenetic. 6 genes have high odd ratios. And there is evidence of copy number variants, and similarly large effect size would be required. There are computerized models which have been generated to analyze the data. So we now have some kind of an understanding into molecular pathology of schizophrenia, which have been confirmed with transcriptomics and epigenomic analysis of post-mortem tissues of patients who died after schizophrenia. There is ongoing research which might, hopefully very soon, identify the biological alterations in the brains of the patients of potential patients of schizophrenia rather than wait for a syndromal schizophrenia illness. Perhaps in future, near future, we might have prenatal genetic testing of a, like they do it for several other birth defects, a prenatal genetic screening for the risk of schizophrenia. And this is not very far. Come back to something of our daily. So we have talked of depression and we have talked of schizophrenia, something that is of great relevance to most clinicians. There is massive research, which is often speculative, on multiple factors that contribute to death by suicide. Today, I read in the paper in Mumbai that the Supreme Court has asked the UGC to develop a model of preventing suicide amongst students. That's a tall order, because suicide is more than a reflex response to stress. It's not that something went wrong and I want to commit suicide. My girlfriend married my best friend, I'm going to commit suicide. It's not like a reflex stress. Worldwide, there have been multiple prevention strategies which are aimed at restricting the access to methods of suicide. Well, they have tried to generate awareness. There are now helplines available. There is outreach of patients who are considered to be at high risk. There are campaigns to destigmatize mental illness and depression. All these measures may be effective in short term, but when you look at the long-term impact, they have not made much of a change in the statistics of deaths by suicide. We do not understand what precipitates suicide. Even if someone's wife runs away with his best friend, that might not be a good reason to commit suicide unless something happens which makes the person want to commit suicide. So we should be able to identify real-time predictors in individuals who are vulnerable to suicide. And we should be able to have, hopefully, identify triggers of suicide. This is feasible. The current modes, though, are rather debatable. There is so much of noise on suicide behavior being associated with psychiatric disorders, and the incidence is higher in comorbid depression and borderline personality. This is not really true. Majority of the mentally ill do not exhibit persistent suicidal behaviors or ideas. Death by suicide is an exception and not a typical sequel of mental illness. Unlike a conception, the typical sequel is childbirth. That's not true for mental illness. A mental illness does not end up in suicide. Suicide is an exception with mental illness, whereas childbirth is the rule with conception. There's a difference. It's not a linear relationship between mental illness and suicide. So suicide behavior is independent of severity and duration and diagnosis of a mental illness. Then there is suicide ideation. Suicide ideation is more frequent than behavior. Ideation does not always progress to behavior. If suicide ideation were to have progressed to behavior, a lot of us would not be hearing this program today. Timely intervention would ensure that ideation does not progress to suicidal behavior. But how do we identify the person at risk? We do not have perfect understanding of psychopathology and cognitive traits of mental illness, suicide ideation, or suicide behavior. But there is now a stress diathesis model of suicide behavior. What do I mean by stress diathesis model? Or not I mean, what does the literature mean by this stress diathesis model of suicide behavior? Let me cite an example. This happened in 2021. There were studies, meta-analysis of studies have tried to predict specific suicide behavior or related outcomes. So, this is that example of that appeared in the India Today on December the 3rd, 2021. A medical doctor murdered his wife and 2 children in a state in India. There was a diary found at the site of the murder where the doctor was not traceable, and he had reportedly written that Omicron will kill everyone. The doctor was not found, but later, the doctor who was actually head of forensic department at a hospital in that particular state, his decomposed body was recovered from down the stream of river Ganges, from a state where Ganges does not flow. The papers called him the doomsday doctor, which is rather unfortunate. The point then is, the suicide behavior is the end result of a very complex interaction between external stressors, internal stressors, and diathesis. So what is diathesis? It is a person's specific factors that moderate the response to stress and enhance the risk of suicide. The neurobiological correlates of diathesis would become the biomarkers of suicide risk. But the biomarkers of suicide shall be different from biomarkers of a mental illness. Currently, we don't have biomarkers, but we have identified risk moderating traits. One is the way the person responds to a stress. People who subjectively perceive even a minor stress as very severe, where the perception of the severity of the stress is out of proportion to the precipitating event. Subjective inclination towards negativity and impaired decision making. On the lighter note, in my first week of housemanship, junior residency in psychiatry, my senior registrar then, Dr. Apte, took me to the orthopedic registrar to see a patient of fractured femur who was lying in the ward for the past 2 months. And his main problem was he would pick up a roti and say, "This chapati is gold. I don't know where to begin." And he would throw it out. And when we asked him the question, "Why are you so keen on starting eating the chapati from a corner?" He said, "But if chapati is so round, how will I reach Dadar from Parel?" We found an easy solution. We removed the chapati and gave him a slice of bread. He was very pleased because he could see a corner and could start eating. So the perception of the stress, where he became excited and was violent because he could not figure out where to start eating the chapati, is by all means perception which was much severe to the intensity of the stress. And this was the person who was inclined towards negativity. Because I can't find out where to start eating my roti, I might as well not be able to, will not be able to reach Dadar. He could not make a decision. And he was aggressive. There are many other people who can't make a decision. Main to nahi karunga, aapko bhi nahi karne dunga. Impulsive, aggressive also are vulnerable to suicide. Then there are contributing factors. There is impaired new learning. They are very rigid in their behavior. They have inflexible and self-centered attitudes and demands. They have selective memory. And they distort, come to inflexible, irrational suspicions. We see this, everybody is robbing me. Now I've become a Miss Zero. All my wealth is removed. Everybody has robbed me of everything. I am now going to commit suicide. That kind of patients we all have seen in our practice. So, suicide behavior following subjective distress is linked to familial transmission of suicide behavior. And these include pervasive subjective sense of helplessness, subjective depression, and past attempts to escape sad thoughts. We have seen this in families. There are some families who have committed suicide. We see these newspaper items every now and then. People who have ability to make proper decision, but have some triggers of suicide. They are high lethality attempt. They make a cold-blooded attempt which is potentially high lethality. These are the people who ignore immediate gratification. They don't look at the current happiness, but they look at delayed negative rewards. Abhi to acha hai, aage jaake bigdega. These are also the people who have similar experience or relatives who also think alike. And this explains familial traits. The whole family, which is very intelligent, but negativity thinkers. They have greater executive control in organizing their behavior, and they attempt high lethality suicides. So people who talk of suicide without being emotional about it, who talk about it in a cold-blooded manner, are the people that we should be careful of. They have poor language and their cognition is pessimistic. They perceive lack of reciprocal caring relationship. Nobody likes me. I'm separated. I'm a minority. All my neighbors are against me. They do not seek help from the others. They only stick to their own like-minded people. They have impaired social integration because they are too engaged in feeding their own negative thoughts. Their memory is impaired. They cannot think of anything good that has happened in the past. They cannot think of long term. They think of immediate solution to their negativity, and they have poor relevance of happy events in their life. Then there is epigenetic etiology of suicidal ideation and behavior, the heritability. There is moderate heritability of suicide ideation and behavior independent of the fatality. And this suicide behavior is independent of other mental illness. We probably believe at this point in time that it's a polygenic inheritance. There has been this genome-wide association studies. Their data is not replicated yet, but there are probably 40 genes associated with suicide behavior independent of the mental illness. Suicide-related genes are associated with inflammations, HPA axis, GABA and glutamate transmission abnormality, neurogenesis, energy production, and tyrosine metabolism with poor circadian rhythm. So they don't sleep very well. There is this epigenetic etiology through brain imaging, which has found dorsal and ventral prefrontal cortex abnormalities and rostral and dorsal anterior cingulate cortex gyrus. They have abnormal decision making. They have heightened sensitivity to negative facial expression. Everybody is staring at me badly. Look at everyone. They are all against me. Social distortion. Some of the political leaders have this, and they are prone to suicide behavior. The political leaders are not. Then there is deficit in serotonergic release in the ventral prefrontal cortex and the cingulate. The clinical correlates is these are the people who have high lethality suicide behavior. There is high rates of death by suicide in patients with defective serotonin mechanism. And then abnormal glutamate and opioid systems, they correlate with deficits in memory, learning, and deficits in reward system. There are structural changes in the hippocampus. Correlates are impaired learning, impaired decision-making, and impaired memory. And larger volumes of prefrontal cortex, huge forehead people, they have high lethality suicide attempters. Clinical correlates is that they have very fine, very high planning abilities. And we see this high top-level executives committing suicide. We see this with increasing frequency now. They have greater caudate volume, and these are the greater caudate volumes are associated with violent suicide. Smaller dorsolateral prefrontal cortex and smaller ventrolateral prefrontal cortex in adolescent attempters, whereas dorsolateral with family history of suicide is also recorded. The resting functional MRI studies is there is some kind of a functional disconnectivity in the default mode network. I'll come to that. Clinical correlates is they have these ideas of reference and they have poor social contact and social cognition. Greater activity in ventromedial prefrontal cortex, greater resting in prefrontal oculofrontal cortex and amygdala, and greater resting activity. These can be studied with functional MRI. There are protocols in functional MRI and PET scan that can actually identify these functions. So, increased frontal subcortical connectivity in suicide ideas in patients with suicide ideas who do not attempt suicide. Because these are sometimes the guys who have better control, better executive control, and they are able to hold back that death wish in the larger context of their lifestyle. The task-based MRI had two groups of attempters versus non-attempters with identical clinical diagnosis, so depression and psychosis and drug use. They were given test exercises of decision-making, tasks to evaluate executive functions. This is a default network. And the attempters were less, they had less activity in their dorsolateral prefrontal cortex, in their anterior cingulate cortex, thalamus and insula. When these patients were asked MRIs, like recall the autobiographic memories, they had studied the brain areas associated with autobiographical memories, and they had less activity in response to positive facial expression, but greater activity. I'm sorry? Like this case, I don't like the tone of your I do. The poor fellow on the day of marriage has an issue. So, talk of neurotransmitters. We know this, we have been studying this right since our MD days, so I'm not going to spend more. But future risk of high lethality suicide can be assessed by CSF5 HIAA, which is not really practical. There are other studies on NMDA and dysregulation, but these are not accessible for us to access before the event occurs, though these are the patients with high buprenorphine response. Continuing with heritability, there have been patients who have altered stress response. I'm not going to go into the details of this, largely because I think we are running short of time, but there is data from association studies that find this. The stress response syndrome in clinical application has noradrenergic activation. There are high levels of CRP and higher severity. So some kind of a neuronal inflammation is associated with high suicides. Application. Suicide is a distinct mental illness. There are structural and functional brain abnormalities that are clearly elicited in suicide. Brain pathophysiology and its relevance to inheritability of suicide is also explored. And abnormal pathophysiology and its correlation with lethality is illustrated, and this can be probably assessed on functional MRI. Real-time monitoring of acute cases will elicit specific data of clinical relevance. There will be improved insight in suicide risk and triggers to help us prevent this suicide. There is implicit association test in its, which is still, the test is not for infants. The test itself is in infancy. And at the clinical interview level, though the patients tend to deny suicidal wish, there's possibility that implicit association test might identify a neural signature or a biomarker of suicide risk. All the clinical centers and at primary or tertiary care centers are addressing this terrible malady of deaths by suicide with constraints of clinical acumen. So another application, once we get a better understanding, we'll sharpen our skills and prevent suicide. On a lighter note, another application of patients who are at risk of suicide is this. I told my psychiatrist that I have suicidal thoughts. So what did the psychiatrist do? Well, now he's making me pay in advance. This is not the best approach that we can think of. Since we are talking of recent advances or trends, there is a whole lot of psychiatry and technology. As it happens, Ipsit Vahia is leading this research at McLean and MIT, and I don't want to kind of do something which might not be correct. But one word, 2 slides, on artificial intelligence and robotics. Medical robots assist surgery and hospitalization in 5 minutes. And they do the histopathology and x-rays. All this helps the clinician to spend more time with the patients. The whole use of artificial intelligence is not to replace the doctor, but help with the back office work so that the clinician has more time to spend with the patient. In the era of robotics, it may sometimes happen before the artificial intelligence robot can anticipate and respond to unexpected anatomy and pathology of the mind. All those figures that we had, or all this data that I gave about overactivity or underactivity of various areas of the brain in the prefrontal lobe can probably be understood by AI and can give us a warning beforehand. But when time comes, robo will not get tired. So 24/7 robots will be available. Robots will not have trembles even after, because they won't drink probably. They would provide evidence-based answers and not guesswork. And the usual 4% error will not occur with robots. At this point in time, the ChatGPT is trying to do some work that the clinicians otherwise would want to do. But I think that won't occur in our time. Robots do support housebound individuals and take nursing care of the housebound individuals with great amount of success. So, ladies and gentlemen, in conclusion, I would say that medical science is progressive and dynamic, unlike religion or history. But it's an approximate science. It is not rocket science. There is a shift from evidence-driven to evidence-based practice of psychiatry. Absolute truth eludes the practice of psychiatry and medicine in general and mental health in particular. There is endless scope for evidence-based new learning. Practice of psychiatry was born out of unusual cases of neurology, and contemporary psychiatry is inching back to neurology. Psychiatry teaches us that unique skill of responding to symptoms without physical dimensions, which no other branch of medicine does. Molecular and translational psychiatry are about to reveal newer strategy for mental illness. The use of artificial intelligence will take care of back office tasks, and we will spend more time with our patients, caregivers, and stakeholders. Thank you, ladies and gentlemen. Thank you for being so patient and giving me some extra time. Thank you.
Thank you very much, sir. A very lucid and exhaustive presentation, as always there. Doctor. Hello.
Yes,
Yeah.
so I think there's a little bit of a problem with your network.
Yeah,
So if with your permission, if I could just read out a few comments or questions posted in the group.
So very nicely, Dr. Vahia has delineated this psychiatry from history to development and to the recent advances and the future of the psychiatry. A very lucid presentation, sir. And thank you, sir. And Dr. Sunil Mittal is here. Yes, please, sir.
So kind of you to say all these nice things.
And Dr. Sunil Mittal is.
I wish my wife and children were here to listen to that, huh?
Dr.
So we go through the questions. I see a few of them here on the chat box.
Yes.
You want
Dr. Sunil Mittal is here. So before we go for question answer session, I invite Dr. Sunil Mittal to say a few words about the subject and the presentations.
Thank you, Dr. Dutt. But after what Dr. Vihang Vahia said, saying anything is, like showing a Deepak to the sun. So thank you, Vihang. That's all I can say for this wonderful, presentation. And right, sort of last 800 years of the travel, and then how I like this particularly that you began on a very vast note and then just zoomed into what's happening right now, the molecular and the translational biology and how it applies to psychiatry. I won't say anything more. Thank you.
Thank you, sir.
It's been brilliant, like always.
Thank you, sir.
And all I can say,
Truly grateful.
I had another parallel meeting to attend to, but I excused myself from there and hung on to every word that you had to say.
I'm sorry to make you miss the meeting.
No. It's I'm delighted to be here because this is so rewarding.
Thank you, sir.
So Dr. Ruxida, kindly take the questions from the audience, and Dr. Vahia is there to answer the question.
If you want, I'll read the question and answer them myself.
So entirely your prerogative. If you
Right.
would rather, I
So
filter it.
let's
Fine.
begin with
So,
Ali.
before we start, there's a direct a message to me. That's why I'm reading it out. They would like for you to share your last slide, because I think some of us might want to take a screenshot of it. So whether you do it now, while you're talking to.
I'll do it right now. I'll do it right now for you, boss.
Yes,
The
sir.
last slide was so simple. Is this the slide they were looking for? Or the
Uh,
one before this?
Not before this.
Not this. The one before this. Okay. This slide,
Yeah, I think.
is this the slide, Rukshida? Sorry. Is this the slide the person is looking for? Dr. Rukshida?
Yes, sir. So I'm sure they'll take a screenshot of it, and if you would like to start addressing some of the comments or the questions, or I'm happy to filter them out for you, sir, if you like.
Well, I don't think there are too many, and unless we run short of time, we will finish them all. So to begin with, Dr. Saddique, thank you very much for the good wishes that at the beginning of the talk. And Dr. Prasenjit Ghosh, thank you very much. 2002 and now 2023, long time. I remember meeting you in Guwahati, and I enjoyed it here. Dr. Pankaj Kumar, thank you very much. Nice presentation, and okay, that's fine. Then Dr. Shashira has wished good evening to everyone, and Ruma Bhattacharya said, suicide, why is it said that suicide are preventable and bipolar disorder is to be treated? Then, Dr. Ruma, this was probably the gist of what I said, that suicides would be preventable if we have some markers. At this point in time, we have idea of some of the traits of a person who is vulnerable to committing suicide. We do not have markers. These are traits which have to be observed very carefully, not just by the therapist, but also by the family members, of a person becoming unusually quiet, reading news about deaths, asking questions about deaths, experimenting with some injuries, with minor overdoses, something to say that all is not quite well. And if you identify these traits, negative thinking traits, always thinking pessimistic about everything, the worst possible outcome of one of the happy events in life are the ones who probably merit an extra attention. I can think of a 28, 6-year-old lady who was a brilliant student in the class. Since her SSC, she had become slightly reserved, not meeting with people. And now she was convinced that she is going to fail. So she told her father about 5 years ago that she was going to commit suicide because she was quite sure that she will not pass her exams, despite the fact that she had scored very high in the last qualifying exam. And the father and the mother, educated, stood with the girl, didn't leave her alone. She managed to pass eventually. After a little gap, she came last week dancing literally because she has now graduated with flying colors. Actually, she has post-graduated with flying colors. Now, this lady, had the parents not observed a change in her personality, had not been kind of spending time with the girl, they would not leave her alone at home. Either the mother or the father or the elder brother would be at home whenever she was at home, are the ones that probably prevented her from committing suicide. So we have to look at the traits till such time that we get the biomarkers. We don't have the biomarkers at this point in time. Dr. Shashi Rai's question is that, is it wrong when we say 85% of the people who commit suicide are suffering from mental illness? Probably yes. So depends upon how you look at the statistics. The actual act of committing suicide, barring the ones who do it as an impulse or barring the ones who do it under the effect of an alcohol or benzodiazepine, last few moments of before ending the life would be spent in some kind of depression or a delusional thought disorder. But that is not mental illness. 85% of the people who commit suicide would have had a negative mental state at the time of committing or attempting whichever the successful or unsuccessful suicide. But to say that 85% of the patients of mental illness commit suicide is not correct. The example I gave is that mental illness does not automatically lead to suicide. The example I gave was that of conception. Any lady who conceives, the end result is childbirth, unless aborted. This doesn't happen. All mental illness commit suicide unless aborted. That's not true. Largest number of mentally ill patients don't commit suicide. So the state and the trait, and just a few weeks or days or hours before attempting suicide, there might be great emotional turmoil, not necessarily an illness. That is my answer to your question. So those who are suffering from mental illness would probably not be true. Largest number of time we see these cases where parents say, I don't know why somebody committed suicide. Largest number of time we have hostel mates who say, oh, she was so nice with us. Yesterday night we had dinner together and at night she committed suicide. We just don't know. Then the boyfriends get caught or the families fight. But we honestly don't know. They are not suffering from mental illness all the time. All the suicide risk genes have, wait a minute. That is Dr. Leoncourt. All suicide risk genes have relationship with brain function. So is it fair to say that 40 genes are independent of psychiatric illnesses? That's becoming contradictory. Well, it's not contradictory. Genes, the current thinking is that suicide and mental illness are not interlinked. And the factors that produce mental illness are not the same factors that produce suicide. So researchers on suicide have identified this as independent of psychiatric symptoms. Psychiatric symptoms itself has genetic preponderance or genetic propensity, but suicide and mental illness are not directly linked. There might be common genes, but they are not directly linked. That is what the research tends to tell us today as I understand it. If somebody else has a better understanding, please share it with me. Dr. Harvandan Kaur Bedi says, so are these changes cause or effect, please? I just answered this. We don't know. We don't think they are cause or effect. They are two independent phenomena. Mental illness and suicide are at this point in time associated but not cause-effect relationship. That would be my best answer to this. A person who threatens suicide while on MSc, should it be taken seriously? Well, Harvandan Kaur Bedi, madam, please, all patients who talk of suicide, who say, maybe I'll never see you again, doctor, or they say, which are the drugs that are suicide prone, which are the medicines that can kill me peacefully, take all of them seriously. Strictly in medico-legal terms, we are probably facilitating suicide of a person who wants to take overdose. I'll tell you why. The general, when you look at tricyclic antidepressants, the general equation that used to be often promulgated was 10 times the recommended or the maximum dose of a tricyclic antidepressant is the lethal dose. So if we have a patient on, say, amitriptyline, 150 milligrams per day, 2 tablets at night, and we give a prescription for 15 days, 10 times the dose would be fatal, and we are already giving prescription for 15 times the dose. So there is an inherent paradox in what's happening. But if a patient threatens suicide, or if there is something for you, when you're seeing the patient over a period of time, you say there is something changed in this person, become kind of, facial expression has more become mask-like, not answering question, take this patient very seriously. Never over-treat suicidal idea, but never miss it or take it casually. Dr. Ashutosh would say that, is there a role for fMRI in day-to-day practice today? Well, Ashutosh, this is a question which you and I have talked about in the past. I have talked about this with Dr. Desai. There is indication, but not 100% reliability of that data. But the time where you do an fMRI study to find the biomarkers of suicide proneness those days are not very far. We'll find it sooner, probably not in my lifetime, but in your career for sure. So Kanak Durga wants to know, oh, she says, Kanak Durga is very happy with her. Oh, thank you very much, Dr. Durga. I appreciate. Shaiza Kausar wants to know, oh, she also found me very enlightening. Oh, so how nice. I should keep these comments and read them when I feel depressed. Shashi Rai, Doctor, thank you very much for your appreciation. Prabir Singh says, excellent and thoughtful presentation, Dr. Vahia. Thank you, Dr. Prabir Singh. Dr. Ruma Bhattacharya says, can we get the whole presentation anytime, Dr. Bhattacharya, write to me directly. A lot of people, Dr. Arsami feels wonderful and thought-provoking. So nice. That was the idea, that all that we can do is think slightly differently. I think this is okay. Any role for fMRI in any literature available regarding response to lithium monitor with serial fMRI? Well, we'll have to look for it. I don't have, Dr. Shazi, I don't have this data offhand on me, but my request is write to Ashutosh. She's damn good at digging up literature. So write to Ashutosh. She'll, I'm sure, find it out for you. I do that. When I need some data, I phone up Ashutosh and he gets it for me, sometimes within minutes. So Dr. Jagjot Singh, do we need to change the definition of suicide? Is the intent to die necessary? Well, no. Intent to die, death by suicide. That is the term, not death after intent to die with suicide. I don't think that exists. And a whole lot of people who intend to die don't attempt suicide. So intent to die and suicidal attempt are probably not synonymous, or even awareness is very important. Then who will spread the awareness? Dr. Ruma Bhattacharya will have to spread the awareness. Rukshida Sayyada says, to reduce the stigma, use died of suicide instead of commit. That's true, very true, Dr. Rukshida. Died by suicide. We don't even say died of suicide, because then death is a part of, no, death by suicide. That is the term that we want to use. Death by suicide, not death of suicide. Voices of suicidal intent or thought instead of threat. That's true if it's hallucination, but some of these are autochthonous ideas that I feel this happens on anniversary suicides. I suddenly got this impulse that after having lost my spouse on the anniversary, I became suicidal. There's a sudden autochthonous thoughts. There has been no mental illness in a way, but in a way, extended grief itself is depression. So it depends upon how you look at it, and it's patient specific. Dr. Harbhajan Singh Kaur has said that what she meant was that just speaking about it, irrespective of how she says today we should take it. So the question is, sir, that's what I meant. Just speaking about it, irrespective of how he or she says, as of for today, we should take it seriously. Absolutely every suicide thoughts we should explore and take it seriously. The standard question that I ask is, with all these problems that are going on for last 2 days or 5 days or 5 months or 2 years, have you ever felt that life is not worth living anymore? That's the question I ask. I don't say suicide, but do you feel life is not worth living anymore? And the patient says, yes. Say, tell me more about it. And then the patient speaks. Patients who have vague suicide ideas, or why vague, even serious suicide ideas, do not want to speak out. But if we broach the topic, they open up. This is my feeling. I don't have any data collected, but anytime I've asked the patient when they come for second, third, fourth opinion, and I would say, look, we are suffering for so long. Do you at times feel life is not worth living anymore? Or even when I see patients in general medical wards for chronic illnesses, and I would say, you're suffering so much, did you ever feel that life is not worth living anymore? And you get a prompt, admirable answers, and patients become cooperative because what was weighing on their chest, they now have an opportunity to speak it out. So always ask for death wish or suicidal wish. Dr. Nachiketa Desai, good to hear from you. How do we apply whatever the current literature we have to clinical practice from bench to bedside? That's $1 million questions. And I was hoping nobody would ask me because I don't have the answer to this. I think we have to continuously sharpen our skills and we learn from our patients who might do something terrible, but hopefully not die. And they are the ones who teach us to refine our questioning of the next patient. It's a continuous process of learning. But what I have learned over my 50 years of psychiatry is that if the patient has a glassy eye or doesn't make eye-to-eye contact, then the way I approach is that, look, I would like to help you. And to be able to help you, I need to have detailed story. And if you give me pure history, detailed history, we'll be able to come up with a very specific drug because we are in the era of designer drug. And there is a pill for every ill, provided we know what the illness is. We can't give it a general pill. And this kind of rapport building questions explores what's going on in the patient's mind. That's how I practice my medicine. Dr. Girish Pandey feels that your advice for treating patient surviving of suicide attempt, my approach at a survival of the suicide attempt is don't talk of the attempt. I meet the patient and I would say, I'm so happy to meet you. I'm great. I'm really happy that I have this opportunity of sitting and talking with you. And tell me, what can I do for you? Don't ask him, why did you commit suicide? What kind of suicide? Oh my God, what stupid suicide? No, 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 never. Don't give any of those advice. Everybody has been doing it to him. Don't bombard him with those questions or her with those questions. Say, I'm happy to see you. And you tell me what you would like me to do for you. The battle is not between us and the patient. The battle is between the patient, us, and the suicidal ideas. So be careful of which side you want to be. Don't sit across the patient, but establish rapport with the patient. And the best way to establish rapport with the patient is to say, I would like to do whatever you want me to do for you. Let's make life happy. These are the kind of questions, or these are the kind of dialogues I begin with. I'm sure Rukshida has a better way of doing it. She's smiling. So she has some better answer to this. Actually, everybody is smiling. Even all the faces I can see on the screen are all smiling. So everybody probably would have their own strategy of dealing with a person who has not died by suicide despite attempting to die by suicide. These are the patients. It takes me an hour to interview these patients, and it all begins with, what can I do for you? I think that's the end of the questions, Dr. Rukshida.
Yes, sir. Thank you so much, sir.
Thank you. And my comprehensive thank you for all those who said I was very good.
Sir, and do not worry, I shall personally convey to your wife and your children how brilliant you were and how very loved you are by so many of us.
Yeah. Oh, thank you.
You
Okay.
were
Thank you.
amazing, sir.
Thank you very much, sir, for making second anniversary session a very lively
Thank you.
session
Thank you.
and very much informative and interactive session, sir, as you always do. And over to Dr. Rukshida for final comments and then the vote
Just
of
my
thanks.
one word of thanks to Dr.
Yes,
Priyanka
please.
Banokar. Thank you. Thank you very much, Dr. Priyanka. Yeah.
Thank you so much, sir. And I would like to take upon the opportunity to invite the money man himself, Dr. Prasanjit Ghosh, the treasurer of IABP, for a vote of thanks.
Thank you, Ruksheda, and good evening to all. On behalf of Indian Association of Biological Psychiatry, I express our sincere gratitude to Dr. Vihang Vahia sir for accepting our offer to be the speaker on this second anniversary of First Friday CME series. We are also thankful to our chairpersons, Dr. Sunil Mittal and Dr. Venugopal Jawar, for chairing and moderating tonight's session. Actually, we are thankful to all the office bearers, our president, Dr. UC Gok sir, our honorary general secretary, Dr. Ruksheda, CME coordinator, G. Prasad Rao sir, CME convener, Dr. Nitin Gupta, all the executive committee members, and above all the participants for the last 2 years who have made this program a successful one. So our special thanks to all the participants, all the past speakers, all the past chairpersons, and also to our office assistant, Mr. Khaled. With these few words, it was so nice to listen to Dr. Vahia sir. I hope you remember in the East Zone CME, I was PG student at that time, and you talked so nicely on neurotransmitter. It was a wonderful experience, sir, to listen to you again tonight.
Thank you. Good night.
Thank you and good night, sir.
Good
Thank
night.
you. Good night, everyone.
Good night. Okay. Bye. Bye, Rukshita. Thank you. Bye.
Thank you, Khalid. I think Amita also joined in.
Wasn't actually drinking.
Welcome,
Fish. Is that Henry? Has Henry turned into a monkey? Perhaps.